So, good morning. Today we are going to discuss another valvular lesions, that is mitral stenosis. Mitral valve is the valve which is present between the left atrium and the left ventricle. So it directs the flow of blood from the left atrium into the left ventricle and prevents the backward movement of this blood when there is ventricular systole, so that the blood moves into the aorta and not into the left atrium. Now, what are the causes of mitral stenosis? The isolated mitral stenosis, practically it's the post-rheumatic fever. So rheumatic fever is the most important cause of mitral stenosis. In all young to middle-aged people, when you see mitral stenosis, the usual reason is rheumatic fever. Then we may have other uncommon reasons. For example, congenital mitral stenosis may be present with atrial septal defect, which is called Luton-Becker syndrome. And then in older people, there is heavy mitral annular calcification, which can lead to mitral stenosis. And this annular calcification is usually present along with the calcification of the aortic valve as well. Then very rare syndromes like malignant carcinoid, systemic lupus erythematosus, rheumatoid arthritis, the Hunter and Hurler type of phenotype, Fabry's disease, Whipple disease, and the use of methysergide may be associated with mitral valve stenosis, but these are really very uncommon conditions. So for practical purposes, mitral stenosis is due to rheumatic fever. Now, what happens when there is mitral stenosis? There is impaired flow of blood from the left atrium into the left ventricles. So the consequence is the pressure in the left atrium starts rising, because left atrium has to contract more forcefully to push blood into the left ventricle. So the left atrial pressure starts rising. And the second thing is that since there is a narrowed valve, the inflow to the left ventricle is obstructed as well. So there is diminished flow of blood into the left ventricle. So left ventricular filling is impaired. Now, what results from these two phenomena? When we see the left atrium, you see with the decreasing surface area of the mitral valve, as the surface of the area of the mitral valve decreases, the pressure in the left atrium and the diastolic mitral valve gradients, that is the pressure gradient between the left atrium and left ventricular during diastole, that also starts increasing. So that results in a backward transmission of this pressure. Since the LA pressure rises, it's difficult for LA to push blood into the left ventricle, but the left atrium does not have any valve which can prevent the backward movement of this blood. So this pressure is transmitted backward into the pulmonary circulation through the pulmonary veins, and the fluid may start leaking into the interstitium of the lung, and in extreme cases it may even leak into the alveolar spaces. So because of this, the compliance of the lung is affected and the work of breathing is increased. The patient starts experiencing shortness of breath. So depending upon the duration of mitral stenosis and the degree of mitral stenosis, the pressure in the pulmonary circuit starts rising, and there is more and more leakage of fluid into the interstitial spaces of the alveoli. That results in diminished lung compliance, and there is shortness of breath. Then this retrograde transmission of pressure results in pulmonary hypertension. As this pressure is transmitted backward, the pulmonary pressure, they start rising. When the pulmonary pressure, they start rising, what happens? The right ventricle has to eject against a rising pressure. So right ventricle starts hypertrophying, and ultimately, if this is not treated, patient develops right heart failure as well. So initially, the left atrial pressure rises. This pressure is transmitted backward through the pulmonary veins into the pulmonary arteries, and then the right ventricle has to push against this rising pressure. So the pulmonary pressure on the arterial side also starts rising, and the right ventricle starts hypertrophying, and ultimately the right ventricle fails as well. So when the right ventricle fails, there is congestion, systemic congestion. Patient may have raised JVP, there may be congested liver, and there may be dependent edema when the patient has right heart failure. And this increasing diameter of the left atrium, as the left atrial pressure rises, the left atrium also starts dilating. Because of this dilatation, the atrial fibrillation can start, because with the increasing diameter, the impulses have to travel a very long distance, and with this long distance, it's possible that the phenomena of re-entry starts and the patient starts having atrial fibrillation. When there is atrial fibrillation, the atria are not actually contracting, so that means there is stagnation or stasis of blood in the atria, and this results in thrombus formation, and this thrombus then further can dislodge into the arterial circulation and can result in embolic disorders in systemic circuit. Now, what happens to left ventricle when there is diminished left ventricular inflow? The left ventricular end diastolic pressure and the cardiac output are usually maintained. Since there is a diminished flow, there is a diminished end diastolic volume in the left ventricle. For compensation to maintain cardiac output, the left ventricle starts beating quickly, so tachycardia starts. So these patients tend to have faster heart rate. With severe mitral stenosis, the cardiac output becomes subnormal because the filling of the left ventricle is not adequate, and the cardiac output may drop. And particularly this cardiac output, whenever there is anything which causes tachycardia, for example, exercise, this cardiac output, which is fixed now, cannot compensate for the increasing demands. So the patient starts experiencing shortness of breath. And the situation is further worsened by chronic rheumatic carditis. There may be associated mitral regurgitation, there may be associated aortic regurgitation or aortic stenosis. So all these situations, they further worsen the left ventricular condition, and the patient starts having symptoms of left ventricular failure as well. Then the statistics. The mitral stenosis parallels rheumatic fever. In areas where there is more rheumatic fever, there is more mitral stenosis. This is usually seen in the developing nations. For example, in India, we see 100 to 150 cases per thousand of population. Similarly, in Africa, we see 35 per 100,000 population of patients suffering from mitral stenosis. These symptoms usually start in the third and fourth decade. Sometimes the symptoms are also seen in second decade of life, but most of the patients, they come in with the complaints in third to fourth decades of life. And you see 2/3 of cases of mitral stenosis are seen in females. The reason for this is not clear, why females are affected more. Then what are the symptoms? Symptoms are shortness of breath, systemic emboli, and the compression caused by left atrium, which is enlarged and compresses the surrounding structures. Now, any symptoms, these can be worsened by anything which causes tachycardia. For example, if there is excitement, there is pregnancy, patient has severe anemia, thyrotoxicosis or fever, anything which causes tachycardia worsens these symptoms, particularly the symptom of shortness of breath. And then patient can present with symptoms because of the systemic emboli. When there is atrial fibrillation, atrium is dilated, thrombus forms in, and this thrombus can break off and go into the left ventricle, and then from the left ventricle it can go into the aorta and then can lodge in peripheral arteries. For example, patient may have a stroke, patient may have renal disease, patient have even myocardial infarction. If the embolus goes into the coronary arteries, there may be gut ischemia, there may be embolism into the peripheral arteries, the patient may have limb ischemia. So the patient presents with symptoms of systemic emboli. And then, as mentioned, compression caused by enlarging left atrium. Left atrium can enlarge the surrounding structures which are present around the left atrium. For example, a very large atrium can press the esophagus and patient can have symptoms of dysphagia. Similarly, if it presses the left main bronchus, that results in a persistent dry cough. And if it presses the recurrent laryngeal nerve, patient can have hoarseness of voice. So all these can be the presenting symptoms of mitral stenosis, but most common is the shortness of breath. Then when we examine the patient, what signs we can see? We can see on general physical examination, and then we can examine the precordium. What we see in some patients in general physical examination, that there are pinkish purplish patches on the cheeks of the patients, and these are usually seen in patients who've got advanced mitral stenosis with portal hypertension, and they're usually visible in fair-skinned people. They're in dark-skinned people. They're difficult to appreciate. And then the pulse may show that it's a low volume. Patient may have irregular pulse because of atrial fibrillation. Then some of the peripheral pulses may be absent if the patient has embolized. For example, a dorsalis pedis may not be seen. So any patient you examine for mitral stenosis, if patient has atrial fibrillation, or even if at the time of examination patient does not have atrial fibrillation, do examine the peripheral pulses. When you examine the JVP, it may show a prominent A wave, and in patients who've got atrial fibrillation, A wave is absent because the A wave is because of the atrial contraction. And when in atria are in fibrillation, they do not contract and the A wave becomes absent. And when you examine the precordium, you palpate the precordium, you may have the tapping apex beat, the classical apex beat of mitral stenosis, which is usually present in the normal place. It may slightly be displaced if there are associated other lesions as well. And if the patient has developed pulmonary hypertension, the right ventricle is contracting very forcefully, then you may have a right parasternal lift as well. And sometimes in patient you can palpate the second heart sound. The pulmonary component of the second heart sound is loud in pulmonary hypertension. And in some patient at the apical area, the diastolic thrill may also be appreciated. The first sound is classically loud. There may be an opening snap and there may be a diastolic rumble. So these are characteristic features of mitral stenosis. We see a little bit of detail of the precordium. You see the first heart sound is loud. Patients who got very well moving pliable valves, they have a loud first heart sound, which is appreciated as tapping of the first heart sound. This is seen in the apical area. When the valve gets calcified, the loudness of the sound starts diminishing. So if a patient has a loud first heart sound, it's quite understandable that this patient might benefit from valvotomy. But when the first heart sound is becoming softer and softer, this means patient has calcified valve, and the balloon dilatation of the valve may not be useful, and the patient may require replacement of the valve. Similarly, second heart sound usually is normal. The splitting is normal, but when the patient develops pulmonary hypertension, the pulmonary component of the second heart sound starts increasing, and it may be even palpable. And when we hear in the left upper part of the chest, a loud P2 may be audible. Then we can hear a decrescendo murmur, which is called Graham-Steele murmur, may be present in a patient who got right heart failure and there is pulmonary regurgitation. And then patient may have a pansystolic murmur of tricuspid regurgitation with the right-sided S3. Opening snap. Opening snap is a characteristic feature of mitral stenosis. It reflects a pliable valve. It's a high-pitched sound which is heard just after the second heart sound. As the atrial pressure starts rising, the opening snap starts coming closer to the second heart sound. This opening snap tells us that the valve is pliable, and as the opening snap comes closer and closer to the second heart sound, that means the MS is tighter and tighter. So this can tell us two things: whether the valve is pliable and would be amenable to balloon dilatation, and it can also tell us about the severity of the mitral stenosis if the patient is serially followed. Then the classical low-pitch, rough, rumbling murmur, which is heard at the apex with patient in the left lateral position, and is heard with the bell of the stethoscope. Now, the duration of murmur correlates with the severity. It's not the loudness of the murmur. The longer the murmur, the severer the MS. And in patients who are in sinus rhythm, you can hear a pre-systolic accentuation. That is just at the end of the diastole when there is atrial systole. So atria gives a final kick to the blood in the atrium to be pushed into the ventricle. So that results in another murmur that is called pre-systolic accentuation of the mitral regurgitation murmur. So we hear a mid-diastolic rough rumbling classical murmur of mitral stenosis, and then towards the end of the systole, when the atrium contracts, we get an augmentation of this murmur. This is called pre-systolic accentuation, and this pre-systolic accentuation is absent in cases of atrial fibrillation. Then the murmur is accentuated with exercises, it decreases with rest and Valsalva maneuver. Now the complication of mitral stenosis, as you see, patient may have atrial fibrillation. Atrial fibrillation initially is intermittent, but later on it usually becomes persistent. And the consequence is a thrombus formation. When there is atrial fibrillation, thrombus forms in the left atrium, and if this rhythm is automatically converted to the sinus rhythm, that there is a high possibility then atria will start contracting and will push that clot into the left ventricle, and then it is embolized into the systemic circuit, where it can result in multiple areas involvement. For example, there may be involvement of the brain, patient presenting with stroke, there may be MI, patient may have limb ischemia, patient may have gut ischemia, patient may have renal ischemia. So this is one complication. Then infective endocarditis. Pure mitral valve lesion is less likely candidate for infective endocarditis. If it is associated with mitral regurgitation, then there is a high risk for developing infective endocarditis. Patient may have pulmonary hypertension, and then patient may also have pulmonary edema, and then if surgery is done, patient may have complications because of valvotomy or valve replacement. Then we go to the differential diagnosis. Differential diagnosis includes co-triatriatum. That's a congenital condition in which there is a septum in the left atrium. Then left atrial myxoma and ball valve thrombus, which can block the mitral valve, and they produce symptoms of mitral stenosis, and this can be differentiated with a tumor plop, which is different from the opening snap. And then patients who've got an increased or very high flow against or through a normal mitral valve, they can have a mid-diastolic murmur. For example, if the patient has severe MR, large amount of blood goes back into the left atrium, and this blood now flows back into the left ventricle during diastole. So this high flow across the mitral valve may produce a turbulent sound which may be heard in mid-diastole. And similarly, patients who've got large VST, they can have a mid-diastolic murmur which is functional. Then patient who got endocarditis with a large vegetation attached to the valves can produce features like mitral stenosis, massive mitral annular calcification, and then finally the murmur of Austin Flint type, which is seen in aortic regurgitation when the regurgitant jet from the aortic valve pushes the mitral leaflet and produces a functional narrowing, which can result in mid-diastolic murmur. Then investigation, we go for routine investigation, for example, CBC, serum electrolytes, renal function testing, the liver function testing, and the coagulation profile. The ECG shows a sinus rhythm, or if the patient has atrial fibrillation, you may find atrial fibrillation. There is left atrial enlargement, there may be right ventricular hypertrophy on the ECG. Then we go for imagings. Imaging include chest X-ray, transthoracic and transesophageal echocardiography. We can go for cardiac catheterization in some cases. Routinely, cardiac catheterization in patients of MS is not required because echo is good enough to give you the information which is required for handling a case of mitral stenosis. So we do cardiac catheterization. If there is a discrepancy in clinical and echocardiographic finding, we can go for a cardiac catheterization. That is, the clinical findings are different from echo finding, so we can confirm this on cardiac catheterization. And then patients who've got severe lung disease, they have pulmonary hypertension, and it's difficult to differentiate this pulmonary hypertension is caused by the pulmonary disease or it's caused by MS, and what is the contribution of each into the pulmonary hypertension. Then patients who've got risk factor, we can do cardiac catheterization to see the state of the coronary arteries. And sometimes patients who've got serious symptoms after mitral commissurotomy, in those patients cardiac catheterization may be required. Otherwise, cardiac catheterization is generally not required. Now what we see on chest X-ray, we see a double shadow behind the cardiac cell hood. So we see the enlarging left atrium as a separate shadow behind the cardiac shadow. There may be straightening of the left ventricular border because of the enlargement of the left atrial appendage. There may be upward displacement or splay of the carina. The left main bronchus is displaced upward by the enlarging atrium. So you may have a display of the carina. You may see the bifurcation of the trachea is more wide. There may be prominent pulmonary vessels with upper lobe diversion. You may see the diversion into the upper lobes. Maybe we can see mitral valve calcification and interstitial edema in the form of curly lines. Then echo can tell us a beautiful investigation. It can tell us about the thickening, the mobility, the motion, the calcification, and the subvalvular apparatus, the fusion of the commissures, all can be seen on echocardiography. Similarly, the valve surface area can be calculated with echo. We can see the ventricular and atrial chamber. We can see the presence of left atrial thrombus. We can measure the transvalvular gradient, and we can measure the pulmonary artery pressure. So all these information, that is not only the anatomy of the valve, the surface area, the situation of the cardiac chambers, the presence of thrombus, the pressure gradients, they all can be measured on different modes of echocardiography. We can go for transesophageal echocardiography. The transesophageal echo tells us about the commissural fusions, the valve surface area, and the left atrial appendage. If it contains a thrombus, that can be seen on T very nicely if it is missed on echo. So in patients who got atrial fibrillation and we are suspecting that there may be problem in the left atrial appendage, T is an investigation in which we can see, and then we can plan treatment. The severity of the MS is assessed on two parameters: the surface area of the mitral valve and the pressure gradient between the left atrium and the left ventricle during diastole. So if the surface area is greater than 1.5 but it's less than 2.5 centimeter, this is a mild type of mitral stenosis. The pressure gradient is usually less than 5 millimeters of mercury. But if the valve area is between 1 and 1.5 centimeters square, the pressure gradient is between 5 to 10 millimeter. This is called moderate mitral stenosis. And if the surface area is less than 1 centimeter square and the pressure gradient between the left atrium and the left ventricle during the diastolic phase of cardiac cycle is more than 10 millimeter, this is a severe mitral stenosis. Now the management, it is medical management and surgical management. Keep in mind there is no medical treatment for mitral stenosis. It has to be a surgical treatment. So we see the physiological effects of mitral stenosis which can be managed. For example, secondary prophylaxis for rheumatic fever. Antibiotics used for rheumatic fever, that is penicillin, sulfadiazine, or macrolides or azolides, which are used for rheumatic fevers. The detail of this antibiotic prophylaxis can be seen in the lecture on rheumatic fever. So the secondary prophylaxis of rheumatic fever, it halts the progression of mitral stenosis, and it may be very useful because repeated episodes of rheumatic fever can worsen the existing mitral stenosis. Then patients who've got pulmonary congestion, salt restriction, diuretics, bed rest, and low dose beta blockers, those who are in sinus rhythm may be helpful. Those who are on in atrial fibrillation, rate control may be used. Patients who are in sinus rhythm, we can use either ivabradine or beta blockers, but patients who are in atrial fibrillation, we can use beta blockers, calcium channel blockers, amiodarone, or even digoxin. So these drugs are used to control the rate, because if we control the ventricular rate, the cardiac output starts improving. Because if there is a fast atrial fibrillation and there is a fast left ventricular response, the left ventricular filling time is decreased and the cardiac output is decreased. So if we can decrease the heart rate, the diastolic filling of the left ventricle starts improving. So that can result in a forceful contraction and improvement in the left ventricular output or stroke volume. So that's why we want to slow down the heart so that the left ventricle fills well and can have a good cardiac output. Surgical treatment. Surgical treatment is valve replacement or percutaneous commissurotomy. You see, percutaneous commissurotomy is useful when the patient has pliable valve which is mobile, relatively thin, it's not calcified, and there is no subvalvular involvement. So the valve is pliable, it is mobile, it's a thin valve, there is no calcification, there is no subvalvular involvement. So if these conditions are present, the mitral commissurotomy percutaneous might be useful. We pass in a catheter through the femoral vein into the right atrium, and from the right atrium we go through the interatrial septum into the left atrium, and then we place this catheter into the mitral valve, and then with a balloon we dilate it. This may result in mitral regurgitation, but this is one treatment which is very useful, particularly in emergency situation. For example, if the patient is pregnant and has mitral stenosis, surgery is not a better option. So we can go for percutaneous commissurotomy, and that provides immediate relief. and then we can go for surgical valve replacement, or it's a new commodity, that's balloon expandable valve is implanted. So this is available in very few centers and usually used in patients who've got symptomatic valve with high mitral annular calcifications. And then we are going for, when we are doing the surgery, we can go for pulmonary vein ablation. This can maintain a large number of patients into the sinus rhythm. Almost 80% of the patient can be maintained on sinus rhythm. And then surgical treatment. We place in two types of valves, the bioprosthetic valves and the mechanical valves. The mechanical valves have a very long life, they are very good, but the problem with the mechanical valve is that you require lifelong anticoagulation. So patient has to be on warfarin. And the newer type of anticoagulants, for example, the 10A inhibitors like rivaroxaban, they are not still approved for the valvular type of atrial fibrillation. So in patients have to be put on warfarin, and warfarin requires frequent monitoring. So that is one problem with the mechanical valves, but they have got a longer life. Then we got bioprosthetic valves. They are very good. They do not require anticoagulation if the patient is in sinus rhythm. But if the patient develops atrial fibrillation, these patients also require anticoagulation. And another problem with the bioprosthetic valve is that they need replacement after every 10 years. Almost 20 to 40% of the patient may require replacement of the valve because the valve veers off. So this was about mitral stenosis, and in the next lecture we will discuss another valvular lesion. Till then, goodbye.